Dear colleagues, welcome to the second annual OncoAlert Colloquium brought to you by the OncoAlert Network and our amazing partners at ESO, the European School of Oncology, eCancer, EONS, the European Oncology Nursing Society, MASC, the Association of Supportive Care, CIOG, the Society for Geriatric Oncology, IGCS, the International Gynecologic Cancer Society, and SWOG Cancer Research Network. My name is Gilbert Morgan. I'm a clinical oncologist, displaced Texan practicing in southern Sweden, and director of the OncoAlert Network. The colloquium, which you're about to see, is an end-of-the-year review taking place daily from January 10 to January 16, bringing you the most impacting findings in oncology of 2021, divided by tumor type, and delivered by an amazing hand-picked faculty of world-renowned oncologists, oncology nurses, and of course, amazing patient advocates. This, as with every OncoAlert initiative, has been realized with absolutely no financial support. All the presentations which you are about to see this week will be free, always available, and will require no registration, and we will not be tracking your data. The amazing faculty that makes up our network believes that through working together and making education available to all is the only way to move forward for the development of our field and for the better treatment of our patients. We welcome you to day 4 of the colloquium, where we will be seeing presentations on GI Oncology, Best of 2021, and the EONS sessions. Our presenters are Dr. Cathy Eng, co-director of GI Research at Vanderbilt, co-chair of the NCI GI Steering Committee USA, presenting on colon cancer. Dr. Yelena Janjigian, chief of GI Oncology at Memorial Sloan Kettering Cancer Center USA, presenting on gastric and esophageal cancer. Dr. Pastum Kazi, Director of Colorectal Cancer Research at Cornell, USA, presenting on rectal and anal cancer. Ms. Stacy Hurt and Ms. Allison Rosen, presenting on the patient advocate perspective. Dr. Mark Lewis, Director of GI Oncology at Intermountain Health, USA, presenting on pancreatic cancer. Dr. Niu Sanford, Chief of GI Radiation Oncology at UT Southwestern, USA, presenting the year on GI Radiation Oncology. Moving on to the EONS session, President of the European Oncology Nursing Society, Johan de Munter, RN, from Belgium, presenting on COVID in the workforce, and ending with Dr. Merel Van Klinken of the Netherlands, EONS Executive Board member, who presents on Cancer Nursing Index. On behalf of OncoAlert, our partners, our faculty, it is an immense honor to be able to present this colloquium to you, our colleague. So without further ado, day 4 of the OncoAlert colloquium, and to get us started, Dr. Cathy Eng.
My name is Dr. Cathy Eng here at Vanderbilt Ingram Cancer Center here in Nashville, Tennessee. It is my sincere pleasure to participate in this OncoAlert session. I will be discussing developments in colorectal cancer, and if we have time, I'm just going to highlight a little bit about anal carcinoma, given my interest in this malignancy. Hopefully we can get through some of these key studies, and I look forward to hopefully discussing some of these with you offline. So this is basically the agenda we'll be touching upon. Fast facts about colorectal cancer. These are the numbers still from 2021. We don't have the new numbers yet from 2022, but still a little less than about 150,000 cases per year. About 45,000 of these are going to be consistent with rectal cancer. And once again, this still remains the second leading cause of cancer death for men and women combined. Now, please note below, I always like to highlight that we are always concerned about the increasing incidence in our young onset patient population. So those individuals that are younger than our average age patients of 67 years of age, specifically in blue, those between 20 and 34 years of age over the next decade are supposed to have an increased incidence of colorectal carcinoma. So please keep that in mind. And I want to touch upon colon cancer very briefly. There's really been no new updates, but keep in mind there are current clinical trials. For the stage 2 setting, they are looking at the role of circulating tumor DNA, and this is NRG GI-005, as led by Van Morris, who is the PI from the study through NRG, specifically, once again, known as the COBRA study involving stage 2 colon carcinoma patients. And this is the study design that you're seeing here. It's a phase 2, phase 3 study. Garden is the platform, and thus far, they've enrolled 230 patients out of 1,400 planned. Please note, obviously, because stage 2 is still an area of discussion, one arm is standard surveillance, and arm 2, which is the assay-directed therapy, patients will be considered for standard in the stage 3 setting, standard adjuvant chemotherapy, and obviously if circulating tumor DNA is not detected, active surveillance. So please consider enrolling to this trial if you have it available to you. Also keeping in mind that shortly we hope to see this study open up for stage 3 patients, which is known as the Circulate US trial, NRG GI 008, as led by Arvind Desai and Chris Liu. And this is the study design here, where for standard patients, if no circulating tumor DNA is detected, they will receive standard adjuvant chemotherapy. If circulating tumor DNA is detected, they will then be randomized to CAPOX or FOLFOX for standard treatment or the consideration of FOLFOXIRI. So this is utilizing the Signatera platform, and I look forward to seeing this trial open up. Please also keep in mind for MSI high patients, there is the ATOMIC trial in the adjuvant setting that is available as well. But because we are short on time, I really want to focus on just a few specific trials. So what about metastatic colorectal cancer? We saw this data from Atezo Tribe presented at ESMO last year, and I just wanted to highlight this. This is FOLFOXIRI plus Bev or FOLFOXIRI plus Bev in a 2-to-1 randomized fashion to the investigational arm with the addition of Atezo. These are first-line surgically unresectable metastatic colorectal carcinoma patients. The majority of patients were MSI high. Primary endpoint here was progression-free survival, and as you can see for all comers, the addition of Atezo added a small benefit of only 13.1 months versus 11.5 months for PFS. Once again, this is a very small study, less than 300 patients with a median follow-up of about 20 months. Hazard ratio was 0.69. Now, the response rate, though, was really not that impressive. It was fairly equivalent of 59% versus 64%, and actually, in fact, was lower for the investigational arm, and the p-value, as you can see here, is not statistically significant. But the PFS was progression-free survival. When you looked at the majority of patients that were MSI stable, the p-value was 0.07, so only a difference of 12.9 for PFS months versus 11.4 months. Now, there was a very small subset of patients that were MSI high or deficient in mismatch repair. Once again, really small number of patients, and the median PFS had not yet been reached at the time of this presentation last year. And for the FOLFOXIRI plus Bev, it was 6.6 months. So we may hear more, but once again, very small numbers. What about updates regarding liver-directed therapy? At ESMO, they also presented the EPOC study, which is for second line, looking at the role of radioembolization with chemotherapy. This was presented by Mary Mulcahy, and here you can see it was a 1-to-1 randomization. It was an international study involving 250 patients in the investigation arm and 213 patients in the chemotherapy arm. Patients had to have unresectable disease. They were able to receive second-line irinotecan or oxaliplatin-based therapy. The albumin had to be greater than 3. Primary endpoint here was progression-free survival, and please keep this in mind. It was a total of 428 patients. Here's the key inclusion and exclusion criteria. Patients had to have a PS of 0 to 1, and the bilirubin had to be less than 1.2 times the upper limits of normal. You could have had, if you had extrahepatic disease, as long as it was limited to less than 5 indeterminate lung lesions or lymph nodes, that was permitted. Well, here's your primary endpoint as seen here. Basically for the investigational arm, you can see the PFS was better in regards to 6-month and 12-month progression-free survival with a p-value of 0.0013 and a hazard ratio of 0.69. For hepatic progression-free survival, the same held true, hazard ratio of 0.59 for the addition of Y90 and was found to be statistically significant. But one matter that always comes up, even though it's a secondary endpoint, is that overall survival was not different between the investigational arm and standard chemotherapy. So the p-value here is 0.7229 and the hazard ratio is 1.07. Once again, it always brings up a little bit of controversy regarding the role of Y90. And I, like others, obviously believe there is a potential role in certain patients. There's always a discussion about dosimetry, and I think that the most important thing about when considering these patients is to have a multidisciplinary discussion with your interventional radiology colleagues and your hepatobiliary colleagues, surgical colleagues for more discussion. What about EGFR rechallenge? I wanted to mention this, the Kronos trial, because it is a small study, but I do find it that it is a little, it is important because it does take into account about checking about the role of circulating tumor DNA. And once again, I only want you to take home points. I know there's a lot of slides here, but really focus on take home points. So this is basically looking at the patients if they've received prior anti-EGFR therapy and it had progression of disease. And if you gave them a treatment break on another line of therapy, and if they were still RAS wild type, can they receive additional anti-EGFR therapy with benefit of response? Once again, small study, but here it was actually quite interesting. They had a response rate of 30% when they reintroduced the consideration of anti-EGFR therapy in this patient population. So once again, demonstrating there is potential benefit. And if you have a patient that was RAS wild type previously, definitely you may want to reconsider EGFR rechallenge as long as you've checked their circulating tumor DNA and made sure they're still RAS wild type. Now, I do want to talk about this. This was recently published. This is the G12C patient population. As you know, it's a very small number of patients in our colorectal cancer patient population, unlike the number of patients in non-small cell lung. This was the original phase 1 study that had a dose escalation for patients with previously treated metastatic colorectal carcinoma, and they previously reported their data and then had a dose expansion phase. Now, when they originally reported the results, it was not that favorable as a single agent. They had about a 7% response rate, but obviously that was a very small number of patients. And now we have the data regarding the dose expansion, and this is sotorasib. These are the results. This is just recently published in Lancet Oncology. The N was 62 patients. The overall response rate was observed in 6 patients, or 9.7%, as you can see here. Now, there were some patients that had some stable disease. In regards to PFS, the median PFS was about 4 months. The median time to response was 2 months. I should also mention this is very short-term median follow-up of only 11 months, and about 11.7% of patients had 12-month progression-free survival. So small number of patients, N of 62. I think this indicates that as a single agent, the results are not as impressive as we had hoped for this patient population. And obviously there's more data that is pending because now there are combination trials, as well as other trials looking at G12D. What about your BRAF mutant patients? Well, we saw the data regarding the Beacon trial for the combination of BRAF-TOVI. This was the original study design, as you recall. These were the results indicating for the FDA approved for BRAF-TOVI for the doublet for our refractory BRAF mutant tumor patient population. We then saw the results from ESMO updated as well regarding the Anchor trial. The Anchor trial was to move the triplet combination of the MEK BRAF inhibitor anti-EGFR therapy to the frontline setting because there was a hint that there was an increased signal if you were treatment naive. However, at this year's past ESMO, the response rate, they had a response rate of 50%. Please keep in mind, small number of patients, the N was 40, but the progression-free survival still remained at 4.9 months. So the data is not as impressive as we had hoped, but I think what I really want to highlight, and in full disclosure, I am an investigator, one of the investigators globally for this trial. This is the ongoing phase 3 study looking at the combination with chemotherapy to see if BRAF-TOVI should be provided in the frontline BRAF mutant, once again, V600E patient population, or is it better in combination with chemotherapy? The phase 3 setting has now moved on to the combination with FOLFOX. What about the HER2 subset? Well, we saw some of this data from Destiny. The Destiny trial, as you recall, is basically looking at deruxtecan or antibody drug conjugate. Specifically, and this study was quite nice. It allowed prior anti-HER2 therapy and it allowed greater than 2 prior regimens. What is noted here, and this was presented at ASCO and then updated at ESMO, the primary endpoint here is overall response, keeping in mind HER2 positivity is about less than 5% of our patient population. But I wanted to show you some of these updated results. So this is at the dose of 6.4 every 3 weeks. And this was basically response rate. Here you can see 45%, once again, more favorable if you are IHC 3+ or 2+ and FISH positive. Now, when you really looked at the change in tumor size, though, based upon IHC, you can see here, it was very specific, more so benefit in the IHC 3+ patient population. Here's the progression-free survival, 6.9 months for PFS, and then obviously more in favor of the 3+ patient population again, or the 2+ plus FISH positive versus 2+ and FISH negative, and the OS was 15.5 months. Now, this past year's ESMO, they did update a little bit of data, but not much dramatically. And I'm sorry, it's a bit blurred. Here's just some initial biomarker data. But once again, small numbers. They are now moved on to the Destiny CRC02 study, which is a randomized phase 2 study looking at the dose of 6.4 versus 5.4 in metastatic colorectal cancer. And they hope to enroll 120 patients. So please keep that in mind. Now, once again, results are always more in favor of the IHC 3+ patient population. And I want to highlight here, please do not forget these patients are at risk for interstitial lung disease. It was about 9% of the patient population. And once again, this drug is FDA approved in the gastric setting and in the breast carcinoma setting. So we want to make sure that we address any concerns from the patient regarding potential toxicities. Highlighting once again, what about MSI high patients? Really no new data, but I just want to make sure that for those of you that were unaware, the OS data has been reported and published recently. Once again, this is MSI high treatment naive patients. They were randomized 1-to-1 fashion to pembrolizumab versus standard chemotherapy, and crossover was allowed. This data was previously reported twice as much improvement in PFS if you were MSI high, and please note there was crossover of the KM curves, not as in favor of the MSI patient population initially. The reasons for that still remain unknown, and that continues to be investigated. There's no real clear answer at this time point. This was the response, about 44% for pembrolizumab versus standard chemotherapy of 33%. Crossover was noted though in about 60% of the patients. And basically, here is your final overall survival data of with a hazard ratio of 0.74 for an improvement, basically, and not yet reached. The median had not yet been reached for the OS in the MSI high patient population. Now, it did not necessarily meet its pre-specified primary endpoint because the goal of the p-value was 0.0246, which may have been a bit of a high bar to try to achieve. And once again, keeping in mind 60% of the patient population did crossover. Keep in mind, checkmate 142 of the combination small single arm phase 2 study in treatment naive MSI high patients of Nivo and Ipi is very, very interesting. And the data has been published just recently in JCO earlier this year. Once again, small numbers, 45 patients, but the response rate is quite high, as you can see here, high 60s to early 70s. So what about ongoing trials? In full disclosure, I am one of the national PIs in this study. This is the fruquintinib study, which has now finished enrollment of 2-to-1 randomization, basically in refractory patients that could have received either prior regorafenib or Lonsurf or the combination. This is fruquintinib, which is an oral anti-VEGF therapy, specifically to VEGF receptor 2. And this study basically has completed enrollment, and we look forward to those results. This is Fresco 2. There's the ongoing LEAP trial, which is the phase 3 study currently that is enrolling. I showed this data, which is based upon the early data, which is supporting moving on to a phase 3. This was basically in combination of lenvatinib plus pembrolizumab. They're enrolling, they noted basically in the original pilot study, a 22% response rate. And basically they've now moved on to a phase 3 study of 424 patients. Now, I just want to touch upon this real quick, very quick. Anal carcinoma continues to rise by 2.7% annually per year over the past almost 2 decades. Basically, there's been data to show that IO therapy as a single agent is promising, with response rates of about 10 to 24% based upon phase 2 studies, as you can see here. And then based upon the data from Interact, we now prefer to use carboplatin plus weekly paclitaxel versus 5-FU cisplatin in regards to less toxicities in the treatment-naive metastatic anal carcinoma patient population. As a result, there are ongoing trials. So you should be aware EA2165, which is for high-risk locally advanced patients, so those with node positive or tumors greater than 4 centimeters. This trial has finished enrollment, and this was for the randomization of standard observation versus nivolumab for 6 months. Also, Nivo plus or minus IPI, this trial has nearly finished enrollment. Actually, the numbers are closer to 96 out of 100 patients, and we hope to report some results in the next year or two. EA2182 is to try to reduce the toxicities of chemotherapy for early stage T1, T2, and 0 patients with a 2-to-1 randomization with a reduction of radiation therapy to reduce toxicities in a single dose of mitomycin at 10 milligrams per meter squared. This study is ongoing and being led by Jen Dorth. And we have some randomized phase 2 studies from the French, a modified DCF plus or minus atezolizumab and a 2-to-1 randomization. So the combination of chemotherapy plus IO therapy. And largely in Europe, there's the Interact 2 study, which is looking at retifanlimab, which has shown single agent activity as well. I'm sorry, I forgot to include that slide as well. And that is why it is being pursued in this phase 3 trial, which is a 1-to-1 randomization with the primary endpoint of progression-free survival as well. I'm sorry, and overall survival. And then our study EA2176 here in the United States, 2-to-1 randomization of carboplatin plus paclitaxel plus nivolumab, followed by maintenance nivolumab. So 2-to-1 randomization to the investigational arm with a goal to enroll 205 patients. Primary endpoint here is progression-free survival. So we really hope to enroll to this study, and please consider this in your treatment-naive patients. So once again, thank you for your attention. And if you want to reach out to me via email or via Twitter, I'm happy to answer any of your questions. Have a lovely day. Take care. And I hope you guys enjoy ASCO GI.
Hello, my name is Dr. Yelena Janjigian. I'm a medical oncologist and chief of GI Oncology Service here in New York City at Memorial Sloan Kettering Cancer Center. Today, we will give you updates on gastric and esophageal cancer, where we are in the new year. Lots of exciting studies are read out, and the field completely changed in the course of the year. You can follow me on Twitter at YJanjigianMD for real-time updates from some of these conferences and studies. We'll start with my disclosures, both for consulting fees and travel funds, as well as research support. And dive into immunotherapy for adenocarcinoma. We'll start with adenocarcinoma. Of course, nivolumab in combination with chemotherapy is now FDA approved, irrespective of PD-L1 status in the United States and many countries worldwide. In Europe, we do have restrictions for CPS 5 or greater for use of nivolumab in first-line setting. Pembrolizumab is also approved in combination with trastuzumab and chemotherapy in the United States for HER2-positive disease based on KEYNOTE-811 study, which also read out this year. We used to have pembrolizumab approved in the United States in third line and beyond. That approval has been reversed in July of 2021, so that's another update. And we still have nivolumab approved in Asia, irrespective of PD-L1 status for third line or beyond. And as, of course, pembrolizumab is still approved in TMB high and MSI high status patients, irrespective of histology in the United States and Japan. So let's get started. Let's talk about Checkmate 649. It's a large phase 3 study with up to over 2,000 patients randomized. Patients were randomized and treated irrespective of PD-L1 status, and patients with esophageal, G-junction, and gastric adenocarcinoma were included. This is an unusual factor and was an important part of the design, that adenocarcinoma patients of the esophagus and G-junction biologically are the same and should be lumped together. Patients were treated all over the world with combination of chemotherapy. Again, what's unique about the study is using oxaliplatin as a backbone, and that's an important part of the design. So chemotherapy with 5-FU or Xeloda plus oxaliplatin and nivolumab versus Xelox or Folfox. And the third arm included Nivo 1 Ipi3. So the first two arms, the 1-year endpoint was already published in Lancet. At ESMO this year. We presented the 2-year update at as well as ESMO 2021 oral was the Nivo 1 AP3 secondary endpoint. The dual primary endpoint of the study was Nivo chemo versus chemo. All of the primary endpoints and the secondary endpoints for those arms were met. And the secondary endpoint was the Nivo plus Ipi versus chemotherapy. So let's take a look at the data. What we have here, based on the approval in April of 2021 and now worldwide, is the initial hazard ratio of 0.71 and CPS 5 or greater for the Nivo chemo versus chemo. P-value is clinically and statistically significant, and there's a nice plateau on the curve for the Nivo chemo. And what's important to see is that for all randomized patients, the median survival is also 13.8 months, irrespective of PD-L1 status. For the first time in over a decade, we're able to demonstrate positive study in this space, crossing the 1-year mark for median overall survival, which is really remarkable. Grade 3-4 treatment-related adverse events were higher with a nivolumab combination. Most of these combinations are associated both with chemotherapy side effects and immune checkpoint inhibitor side effects, but these were tolerable and managed 59% in 59% of patients, grade 3-4 treatment-related adverse events. Well, what about the long-term follow-up? After 2-year follow-up, this benefit still holds. In fact, the hazard ratio directionally improved. This was data presented at ESMO 2021 and will be published soon. So CPS 5 or greater, hazard ratio of 0.71, and CPS in all randomized, irrespective of CPS, hazard ratio of 0.79, directionally still improving, median overall survival difference clinically and statistically meaningful. And for that reason, many countries, many regulatory authorities decided to approve immunotherapy in first-line setting, irrespective of PD-L1 status. The patient population that you need to be particularly aware in gastric and esophageal adenocarcinoma is MSI high status. Those patients are rare. Only 3% of the patients in the study were MSI high. Nonetheless, the overall response rate is higher, 55%, median OS of 38.7 months, compared to 12 months with chemotherapy, again, suggesting that MSI tumors may have chemotherapy resistance inherently, and MSS tumors look exactly the same. Well, what about the overall survival for Nivo Ipi? Unfortunately, that was a negative secondary endpoint. Median OS was not statistically or clinically different between Nivo Ipi compared to chemotherapy. Hazard ratio is 0.89. And as very typical for chemotherapy-free first-line studies, the initial crossover occurs with Nivo Ipi, and then subsequently there is a benefit. But however, this degree of difference was not meaningful enough to show a favorable hazard ratio in the end. So in CPS 5 or all randomized patients, the curves look almost identical. Well, what about response and response duration? The PFS was also not different, but the response rate, what's interesting is overall response rate for Nivo Ipi is 27%, which is almost identical to what we saw in CheckMate 32 study, which was in later lines of therapy. This data was already published many years ago, and what led to the CheckMate 649. So we used Nivo 1 Ipi3 in CheckMate 649 because of the CheckMate 32 data. Here, the median duration of response is 13 months, nearly doubled to what was expected with chemotherapy. Again, suggesting that since MSI status is so rare, then there's a population of patients that tend to benefit from these regimens. And PD-L1 does not appear to be the factor. MSI is probably not enough to explain the 27% response rate. But if there are patients who respond, their response is durable. Of course, the only problem is that most patients respond later on and may not be enough to treat the large disease burden. Well, what about Nivo-Ipi with MSI high population? Overall response rate at 70%, so higher numerically, although the numbers of the patients is so small here, it's hard to draw definitive conclusions. This is certainly provocative data. Median OS is not reached, and who would not want to be on this curve? It's so nice and flat, and certainly, it's a very provocative data to suggest, again, there's a population of patients that may benefit from dual inhibition. Let's talk about PD-L1 testing. 28A DACO antibody was used in Checkmate 649. Most Merck studies and most also sintilimab studies are using 22C3. What the problem is that most patients in standard practice get several of these different antibodies tested, although they're controlled and found to be reproducible in research setting or in controlled environment. In clinical practice, you can tell, I'm sure you experience this, the PD-L1 CPS5 cutoff is not as reliable, and often positive patients subsequently test negative within the same tumor sample and vice versa. And the reason why is that CPS is an extremely subjective test. In other words, if you put 10 pathologists in the same room, they often disagree or not. It's not a concordant result within different pathologists. If you have a study pathologist that's reviewing all the samples together, certainly that's very reliable, and that's what we demonstrated. When Checkmate 649 data came out first, the CPS5 or greater 60% in 60% population was thought to be an anomaly. It was thought to be higher than expected. But since then, several other studies demonstrated the exact same positivity rate. Again, for example, Orion 16, which is the sintilimab data set, 62% positivity rate in first-line setting, again, suggesting that if you have a good controlled sample that goes through QC and it's the same pathologists reviewing it, there's a high rate of concordance. However, all the clinical caveats are usually not the same. This table is meant to summarize the data for, there's so many now anti-PD-1 and anti-PD-L1 inhibitors on the market, many of the positive studies coming out of Asia and other countries. And for adenocarcinoma, a lot of these inhibitors appear to be similar. So for adenocarcinoma in the United States and worldwide, nivolumab is really what is used in first-line setting for HER2-negative disease. And now we can talk about HER2-positive disease. Well, so Keynote-811 is a phase 3 study that read out for a first interim analysis this year. And we looked at HER2-positive tumors for IHC 3+ or IHC 2+ FISH positive, irrespective of PD-L1 status. This is based on MSK phase 2 data and also South Korean phase 2 data suggesting great benefit in those patients. In our phase 2 study, we demonstrated 91% response rate for the combination of pembrolizumab, trastuzumab, and chemotherapy, which is nearly double from what is seen in the TOGA study with trastuzumab chemotherapy. That was 47%. So because we expected a very high overall response rate, we wrote in a interim look for overall response rate into the study. Patients were treated with pembrolizumab, trastuzumab plus chemotherapy versus placebo, trastuzumab, and chemotherapy. So double-blind, placebo-controlled study. The dual primary endpoints are OS and PFS, and pre-specified secondary endpoint was overall response rate. So with pembrolizumab and trastuzumab chemotherapy, what we saw for the first time in a large phase 3 study, an overall response difference of 22.7%. So 23% overall response difference, and this compares to 15% overall response rate difference that we saw in Checkmate 649. So suggesting that there may be an additive effect of the anti-PD-1 plus anti-HER2 inhibition. The overall response rate in the experimental arm was 74%, and in 32% of patients, we saw greater than 80% decrease. So very deep responses, as the waterfall plot shows. 11% had complete response, which was, we still have patients that have been cured. Grade 3-5 adverse event rates did not differ between the treatment arms. And based on this exciting response and good tolerability, the FDA approved this drug in combination with pembrolizumab and trastuzumab in May of 2021. So in April, end of April, we had approval for nivolumab in HER2-negative disease. 2 weeks later, on May 5th, Cinco de Mayo, we had approval for pembrolizumab. Let's talk about squamous cell cancer now. Well, so in squamous cell cancer, we also have pembrolizumab in first-line setting in combination of fluorouracil platinum. Nivolumab and ipilimumab are also being explored and under review based on CheckMate 648 data, as well as 5-FU platinum and chemotherapy. These improve survival compared to chemotherapy alone. And unlike adenocarcinoma, in squamous cell, we do have second-line therapy approved, pembrolizumab and for second line and beyond, and nivolumab, again, for squamous cell cancer. So Keynote 590 read out this year that looked at pembrolizumab plus chemotherapy versus placebo plus chemotherapy. And this was a positive study for esophageal squamous cell cancer in particular. Higher percent of patients are CPS 10 or greater. And then now patients, the hazard ratio is 0.57, really dramatic improvement. For all comers esophageal squamous cell cancer, hazard ratio of 0.72. So I think about Keynote 590 as a squamous cell study primarily. There was a small percentage of adenocarcinoma patients enrolled, but it was, I'm largely discussing the squamous cell data. CheckMate 648 also looked at squamous cell population, looked at Nivo plus chemotherapy. Again, note the use of cisplatin. Cisplatin is extremely toxic at these doses. I would not recommend it. For CheckMate 649, we really mandated use of oxaliplatin, and it's been well regarded and accepted. Nivo 3 IPI-1 was used here, so the lower dose of IPI, and the comparator arm was chemotherapy alone. Primary endpoints of OS and PFS. And again, these were squamous cell patients that enrolled. And Nivo plus chemo versus chemo, very similar data in CheckMate 648, median OS of 13.2 months in all comers. And here tumor PD-L1 status is shown on the left here. So it's not a CPS, it's tumor PD-L1, median OS of 15.4 months with hazard ratio of 0.54. In that population, which is interesting, right? It's a very nice hazard ratio. Well, what about Nivo plus chemo versus chemotherapy? Remember, chemo plus IO is already available in the US. So the ideal comparator would be Nivo IPI versus chemo plus Nivo. But here we have Nivo IPI versus chemotherapy, hazard ratio of 0.64 for tumor cell PD-L1 grade 1 or greater. And a hazard ratio of 0.78 for all randomized patients, median OS of 12.8 versus 10.4. So the median OS suggests that perhaps you could use Nivo IPI. At least, again, it's hard to compare apples to oranges inter-study comparison, but how does this fit in? When would you use Nivo IPI versus not using chemotherapy at all? And again, the concern here is the early detriment and the crossover, right? So our squamous cell patients come in quite ill, symptomatic, and the concern is that if you don't induce response, the dysphagia will get worse, or they'll develop other cancer-related symptoms and then may not be able to get chemotherapy later on. And so that the crossover is what always worries me. Certainly in patients with high PD-L1 expressing tumors or low disease burden, Nivo IPI could be considered, because the response, once again, if you respond so much more durably, right? So it's nearly doubling for patients with PD-L1 tumor cells positivity, and median duration of response of 11 months in all randomized patients compared to 7 months for chemotherapy. And the overall response rate is similar. So it's 35 versus 20% and 28 versus 27%. So even though the patients, may not have the difference in tumor shrinkage, at least based on the overall response data, the disease stabilization and other factors may derive benefit from chemotherapy combinations. And again, this is chemotherapy only. This is not chemo plus Nivo. So treatment-related adverse events, they look favorable for Nivo-IPI because we have a lower dose of IPI here. Any treatment-related adverse events, grade 3, 4 was 32% with Nivo-IPI and 47% with Nivo chemo, because you're getting both chemotherapy side effects and immune checkpoint inhibitor side effects. And what about squamous cell cancer? We just talked about adeno, and I mentioned that I believe a lot of these newer agents have the same activity. Well, it's interesting. I was able just to summarize some of the squamous data coming out of Asia with drugs like sintilimab and other drugs. Well, it appears to be that in Asia, because of paclitaxel backbone or other factors associated with it, the hazard ratio for survival actually looked a little better for all comers. And the overall response rate was 66% versus 47% with combination of chemotherapy plus immunotherapy in Checkmate 648 versus Orion 15. So the immune checkpoint inhibitor data coming out of Asia is looking slightly different for squamous cell cancer as opposed to adenocarcinoma. And there's a lot of discussion as to what to do with this data. Should we be using paclitaxel as the backbone for chemotherapy and other in combination with immunotherapy? What are the next generation of trials and what's available? How is this Asian data going to affect the West? Let's talk about adjuvant studies, which is what we're going to finish with. Checkmate 577 also read out and published this year. It's a huge year for esophageal cancer as well as gastric cancer. Global phase 3 study looking at patients who completed standard of care esophageal cancer treatment, so which usually included chemoradiation followed by surgery, and had residual disease despite complete resection. So patients who had R0 resection but had AT or N positive disease with a residual cancer left in the surgical sample were randomized to receive either nivolumab for up to a year or placebo with a primary endpoint of disease-free survival. This was published in New England Journal of Medicine this year. What's unique about the study, majority of the patients were adenocarcinoma, so this is very relevant to the Western population. There were GE junction tumors, again, which is what we see in the clinic at the larger propensity. And patients it was relatively flexible randomization criteria, so you don't have to rush to start treatment post-op, and that's one of the learning experiences with doing post-op therapies is our patients are relatively still frail and need time to recover. So you can do it up to maybe 2 months after surgery or even up to 3 months. The disease-free survival was doubled, median disease-free survival of 22.4 months, hazard ratio of 0.69 compared to placebo. This is ground-breaking data. There was some discussion about we need to see the survival data. And yes, that's possible, particularly since now immunotherapy is available in first-line setting. Practically, and as a patient advocate, you can imagine disease recurrence is devastating. So most of our patients, at least in my practice, elect to start immunotherapy in adjuvant setting, particularly for high-risk disease, and they do not wait until a recurrence. Progression-free survival 2 is also appears to be improved, hazard ratio of 0.77. Approaching 1, a median of not reached for the nivolumab. So again, suggesting that there is a benefit for these treatments. Where is the future going in the last 30 seconds? So eradicating micrometastasis with immune checkpoint blockade is really what we're going after. And we need to do this early on early in the disease course, as soon as you diagnose early stage tumor, and really strike while the iron is hot. We're treating both the primary tumor, but also the micromets, and educating the immune system, expanding the T cells so they can really do their work long after the surgery is done. And so having adjuvant therapy available to our patients, this is FDA approved already in our patient population in the US, is great, but neoadjuvant therapy is where the future lies. Matterhorn study is currently accruing patients. I hope you can participate. This is a randomized study of durva plus FLOT versus placebo plus FLOT. FLOT, of course, is the standard in perioperative setting. Of course, Keynote 585 data is also going to be reading out soon. That's for doublet 5-FU platinum with plus minus pembrolizumab in perioperative setting. I thank you for your attention. Happy New Year. Please stay healthy and safe. And I hope to see you in person in the upcoming year. And in the meantime, let's connect on Twitter at YJanjigianMD. Thank you and have a great day.
Hi, my name is Allison Rosen, and I'm joined by my friend and colleague, Stacy. We are both colorectal cancer survivors and passionate advocates. We're representing the colorectal cancer patient survivor community today for the OncoAlert Colloquium. And we're excited to give you a little bit more information about us and what we do as patients and survivor advocates. I will start out and introduce about myself, who I am. I've worked in oncology for 16 years. I started out as a cancer researcher, and as I was working in research is when I was diagnosed with stage 2 colorectal cancer. It was a journey. I could talk about that for hours, but that's not why we're here. But eventually, I got through my treatment. I can now say that I am a 9-year colorectal cancer survivor, and I turned into a very passionate advocate as a result. I also switched careers. So research is so important, and you're going to hear from some amazing researchers today. But I work now in cancer outreach, cancer education, cancer prevention, anywhere that I can work with the community and clinics and health agencies to help increase the colorectal cancer screening rate or just cancer screening rate in general. I basically took what I went through and I helped to bridge that gap between the cancer community and the research community and sort of the healthcare community. So that's a little bit about me. I'm going to let Stacy introduce herself next.
Hi, everyone. I'm Stacy Hurt. Thanks for joining us today. I started out actually in industry as a pharmaceutical executive and also working in physician practice management. So I had worked in that like 20 years until in 2006, when my younger son was diagnosed with a rare chromosome abnormality. He doesn't walk, talk, or function for himself in any way, so I am his full-time caregiver. Then I returned to work, and as head of training and development for a pharmaceutical company, I was diagnosed in 2014 with stage 4 colorectal cancer on my 44th birthday. I had cancer in my rectum, liver, lungs, and lymph nodes. After 55 chemotherapies, 2 surgeries, and radiation, I'm very excited to say that I am now 6 years cancer-free. So I turned my mess into my message and my mission. And now, like Allison, I am a colorectal cancer advocate. I work with patients for better treatment plans. I do that all voluntarily. And then I also, as part of my work, I am a consultant to help, as much like Allison does, I bridge the gap between industry and patient in the form of a patient engagement and patient centricity, and how to further include the patient voice in drug development and biotech device development.
So we're going to talk a little bit about different niches or different aspects of advocacy that we both work in, volunteer and work in, are sort of well known in. And we're so excited to be able to share this information, especially because things have changed a little bit, especially over the course of the past 2 years and the past year with COVID-19. So I've always been very active on social media. You can find me on Instagram, on Twitter, on Facebook. But I had never thought about TikTok until COVID hit. And it really started with when this colorectal cancer screening age changed to 45. The U.S. Preventative Services Task Force this past year lowered the screening age from 50 to 45 for average risk patients to be screened for colorectal cancer. That sparked like, I need to do more. What else can I do? As a 31-year-old, I was diagnosed with colorectal cancer, and people need to start thinking about screening even earlier than 45, especially if they have symptoms. And so I realized that I could use TikTok as I was scrolling through it. I was convinced to make 10, 15, 20-second sort of videos about education related to colorectal cancer, screening, I'm now a permanent ostomate, so I talk about that as well. Really, I wanted to guess take the myths and break them and have people understand that you can live a full life as a cancer survivor, as a cancer patient, and sort of be a voice and help spread the message about colorectal cancer. You can see that there's 689 million active users throughout the world on TikTok. So I realized that when I started with, I think I had like 10 followers when I started, and now I'm up to a little less than 15,000. And these people care, these people connect with me, and these people, I'm able to support them all over the world and provide them resources that they might not know about. And I've also done a lot of collaborations with different organizations, American Cancer Society, the Colon Cancer Coalition, Colorectal Cancer Alliance. But essentially, I can talk all day, but I'll show you one of my favorite TikToks that went viral after I posted it. So let me show that real quick. If you had asked me a year ago if I would put myself in a bathing suit on social media or show my ostomy off on social media, I would have said no way. But I think that I'm fueled by people. I'm fueled by the community. I'm fueled by people wanting knowledge. And my motto has always been educate, advocate, and collaborate. And that's what TikTok and social media in general brings to me as an advocate, and is sort of my platform that I use. So another thing that I'm passionate about, and you might ask, well, how do you know this? Why do you know? Is sort of communication tips and tricks as far as cancer is concerned. So over the past, I want to say 5 years, I've given talks on empathy to medical students. I've taught colorectal cancer to medical students and pharmacy students and MAs, PAs throughout the Houston area. And so through that, I've learned all sorts of different things, along with talking to other patients and survivors and caregivers about communication, and also obviously my lived experience. So really the message here is say this, not that. And so people always ask me, what can I do for you? Is there anything I can say that I can sort of relate to my son or my daughter or my mom or my dad? So these are a few quick messages. There's tons listed on my social media, and there's tons out there all over, but really I want to just highlight 2 of these real quick, and then we'll move on. So one thing not to say is, how can I help? What to say is, what day can I come over? I'm going to bring you this. Don't ask, just do it. I'm always very much like, no, I don't need anything. But really, when someone does bring that lunch or brings magazines or whatnot over to me, that means the world. I don't want to have to ask, and to support somebody, just bringing and being there is great. The other thing that on here that I want to point out is don't say, I'm sure you'll be fine. You don't know if that person will be fine. And that's really hard for someone to hear, especially if they're going through a hard time. So what you can say is, how are you really doing? I'm here to listen. And then just listen, just be there, because no matter what the person is going through, they just need someone to listen to them and be able to vent, because oftentimes people don't understand what a cancer patient or a survivor is going through. So being there to listen is one of the most special, most important things you can do as someone in the community, as someone that cares about someone that's going through cancer. And I'm going to read this last box on here, because really it is so important. And it's a very important message to get across to everybody. When speaking with a cancer patient about their diagnosis, oftentimes people aren't sure what to say. People generally have the best intentions, but words can land the wrong way. Certain phrases may seem insensitive or careless. The fact is, words matter, but people may have trouble communicating appropriately. I have a diagram. I have a bunch of information about all the things you can say or not say. I made TikToks about it. So obviously we have our Twitter handles on the bottom of this, so feel free to connect with us after. But now I'm gonna pass it on to Stacy so she can talk about all the amazing things she's doing.
So an area that I like to educate about is invisible disabilities of cancer treatment. When I was going through treatment, I looked totally healthy. I didn't lose my hair. I didn't lose weight. My coloring was good. And so people just assumed, much to Allison's last slide, that I was fine. And well-meaning, well-intentioned friends would say, Stacy, you look great. But meanwhile, behind the scenes, I had some battles going on that nobody knew about. So since a picture is worth 1,000 words, I created this infographic that sort of highlights some of the challenges that we face as cancer survivors, all of the different scars and side effects left from our treatments. So you just never know what a person has going on behind the scenes. Unlike Allison, I don't have an ostomy. We could add that on. There's so many more that we could add on to this. But again, the point of this infographic is education, to make people aware that just because somebody may look good, they don't necessarily always feel good. I do post this infographic a couple times a year, once on World Cancer Day, which is coming up on February 4th. And then again, during Invisible Disabilities Week, which next year is coming up on October 16th to the 22nd. Next slide. Another area that I do some advocacy work in is in the area of digital health. I am a HIMSS digital influencer, and HIMSS stands for Health Information Management Systems Society. And on the right are some of the areas of health tech and digital health that I advocate about. Three that I want to pull out are, number one is interoperability. And because of the final rule of the Cures Act that was passed on April 5th, patients now have access to their medical records and have a right to see everything that's written about us within our medical record. So it really shifts power to the patient in terms of owning our data and leveraging our data for better outcomes. I'm also an advocate of telemedicine. I sit on an advisory board for the continuance of telemedicine post-pandemic, not to replace a face-to-face visit, but instead as a continuous sort of extension of a face-to-face visit, and capturing what happens with a patient between going in to see the doctor and when they're in their home setting. The other one that's really hot right now is decentralized clinical trials, and that is using technology to really meet patients where we are, to better enroll patients in clinical trials, better adherence, and hopefully better outcomes, all through the use of technology. Next slide. And then these are some of the advocacy groups that Allison and I have worked with. These organizations we would refer you to for patient support, policy development, and research. We want you to know that our advocacy color is blue, as my colleague is beautifully wearing today, and our awareness month is March. So please be looking out for events around March. We're also looking forward to the GI ASCO symposium coming up on January 20th, and what research will be coming out of that.
So with that, we want to end. This is not all inclusive. Stacy and I both do a ton of, a ton of advocacy work, but these are amazing organizations related to exactly what she said: colorectal cancer, policy, research, advocacy, support. Feel free to connect with Stacy and I on Twitter. Our handles are on the bottom. We want to be a resource for you or anyone that you love and you care about. We want to be a resource for researchers. We want to be a resource for the community. We want to be just a clearinghouse. If you have a question, we want to be able to answer that. And if we can't, we can send you in the right direction to the person that can answer that. So with that, I will end it for both of us and just say thank you so much to OncoAlert. We're so excited to be a part of this meeting, and for the patient voice, patient experience to be included in this most important meeting today. So thank you so much.
Hello, my name is Mark Lewis. I am a medical oncologist. I'm the director of gastrointestinal oncology at Intermountain Healthcare in Salt Lake City, Utah, in the United States. And I'm privileged to be part of the OncoAlert consortium. and our fearless leader, Gil Morgan, has asked me to speak at this colloquium on the topic of pancreatic cancer. As we'll discuss, that's actually an umbrella term that encompasses two different main tumor types, but we'll spend the majority of our time discussing adenocarcinoma. And even though this is the 2021 colloquium, it really is addressing progress that has happened over the last several years and during COVID. And I'm happy to tell you that even in spite of the pandemic, research has not been stagnant, and we are seeing advances in this disease to the benefit of the patients whom we treat. So first of all, I'd like to address the layout and the agenda. What we're going to be discussing is recent changes in the management, again, predominantly of PDAC. We're going to talk about resectability. We're going to examine the optimal therapeutic sequencing in non-metastatic PDAC. We're going to understand the indications and implications of germline testing in PDAC. And finally, we'll talk about a new treatment option in pancreatic neuroendocrine tumors, or PNETs. So the first time I hear about the new case of a patient with pancreatic ductal adenocarcinoma, I think to myself, is it resectable? And then that in turn begs the question, resectable to whom? And I put a series of icons next to it because the calculus here is incredibly complex, and I would argue requires input from more than one specialist. The glib answer here is, of course, everything is in the eye of the beholder, and ultimately it is the judgment of the surgeon is going to operate as to whether it is reasonable to undertake procedure. Dr. Hong and colleagues published a still very germane review article on pancreatic adenocarcinoma in the New England Journal of Medicine back in 2014, in which they present this as a continuum, going from resectable to unresectable on the basis of the involvement of adjacent vascular structures. And then finally, of course, the unfortunate presence of distant metastases, which, as we know, are all too common in PDAC. There's a very complicated system by which we try to bifurcate potentially operable tumors from those patients who are likely never to see the OR. And again, there's sort of a pragmatism here in trying to separate out the borderline resectable patients from those who are locally advanced and likely to remain inoperable. So venous involvement of any type puts patients in the borderline resectable category, as does focal and non-circumferential involvement of the superior mesenteric artery and the hepatic artery. You can see here that this table is taken from the latest iteration of the NCCN guidelines. And perhaps my favorite thing about the entire graphic is at the very top, that bullet point that says, decisions about resectability status should be made in consensus at multidisciplinary meetings and discussions. And I think pancreatic ductal adenocarcinoma is on par with rectal adenocarcinoma, and you can argue now distal esophageal and junctional adenocarcinoma as a tumor that must be discussed among multiple different disciplines, including surgery, medical oncology, and radiation oncology. I think that's sort of the tripartite approach to this disease. And of course, there's other colleagues that can play a huge role too. Radiology, of course, is key in helping us discern the degree of vascular involvement here that's so pivotal. Sometimes we need complex endoscopists, gastroenterologists who can perform endoscopic ultrasound to look at these structures. And of course, we can't forget about the pathologists who are really the core of all of our tissue diagnoses. So we're going to talk about this borderline resectable group and how do we improve the likelihood of an R0 result. So there was a fascinating trial that came of age and was presented at the 2021 ASCO GI Cancer Symposium by lead author Dr. Matt Katz, a former surgical colleague of mine at MD Anderson. And Dr. Katz has spoken for years about, again, trying to parse out borderline resectable from locally advanced. He's talked and written extensively about how to consider appropriate vascular criteria, and he's done prior work that has built and led to A02501, which was entitled Preoperative Extended Chemotherapy with or Without Hypofractionated Radiation Therapy for Borderline Resectable Adenocarcinoma of the Head of the Pancreas. And it's a mouthful. It goes to show you just how much nuance we need to invoke here. And Dr. Katz also, through A021101, established sort of quality criteria by which these patients could be properly selected. So they were eligible based on one or more centrally reviewed radiographic criteria: interface with the SMV or portal vein at or greater than 180 degrees, as you see there; interface with the superior mesenteric artery or celiac axis at less or fewer than 180 degrees; short segment occlusion of the confluence between the superior mesenteric vein and the portal vein that was amenable to reconstruction; and interface of any degree with the hepatic artery that was amenable to reconstruction. So those are the patients that very specifically we're looking at in A02501. So you can see the schema there. There's really two things I think that are being tested here. One of which is the role of preoperative FOLFIRINOX or modified FOLFIRINOX as an induction chemo regimen, and then also trying to test the benefit of adding radiation after a great deal of induction FOLFIRINOX before proceeding to surgery. So you can see there that there's two arms of the study, as we'll discuss in some detail. The primary endpoint was the binary 18-month overall survival rate. But key secondary endpoints included event-free survival, the R0 resection rate, and then pathologic complete response rate. I'll also point out that built into both the arms of the study was the intent to administer adjuvant chemotherapy with 4 cycles of FOLFOX to take the total exposure to systemic therapy to 6 months in the perioperative setting. So here's the consort flow diagram. I know this is busy. I know I'm committing the cardinal sin as a presenter, showing you a busy slide, but what I want you to discern here is there was slightly more dropout in arm B, which is the radiation therapy containing arm, before surgery than in arm A, which was only FOLFIRINOX. And in fact, barely half of arm B, all of whom had been randomized, made it to the operating room. And we'll talk about why that might be important in just a second. You'll also notice at the top that once arm B closed, those patients that were still eligible for the study were then sequentially assigned to arm A. So it wasn't actually a split 1-to-1 randomization between these arms as the investigators might have originally intended. So here are the conclusions. And again, this is a slide presented by Dr. Katz himself at ASCO GI last year. So first and foremost, the 18-month overall survival rate of arm A was 66%, whereas it was 47.3% in arm B. But before we jump to conclusions, Dr. Katz himself here has put very helpfully in red and green, he deemed arm A efficacious, and arm B did not meet the requirements to conclude efficacy. And the reason for that is that arm B closed when an interim futility analysis, I believe in August of 2018, at that point, 30 patients had undergone R0 resection. That was 30 patients undergone resection. That was the trigger to look at the data. And 10, or a third, had achieved R0. And that was deemed the signal for futility, and that's when that arm closed. And then the patients shifted over to arm A with further enrollment. You'll note here that the resection rate was almost exactly half in arm A, barely over a third in arm B. The pathologic complete responses were not seen at all in arm A, whereas there were a few in arm B. And you can see also that the rate of preoperative adverse events was slightly higher in arm B. So, in trying to dissect, no pun intended, what happened here, there was a fantastic review and critique presented by Dr. Ted Hong at this year's ASCO meeting. And he posed the provocative question, were the arms of 802-501 equal? And specifically, he was asking, was the radiation group at higher risk? And what Dr. Hong sussed out, as had Dr. Katz, was that the median CA19-9 level was higher in arm B than arm A. Metastases prior to resection seemed to happen at a higher rate in arm B. And he asked, Dr. Hong asked, is it plausible that a single cycle of FOLFIRINOX contributed to such a discrepancy in metastatic rate, essentially a doubling? And ultimately, he concluded that the numbers, the N's, were too small to be sure. And then there were other commentators like Dr. Rebecca Schneider, and I'm just going to quote her here, said, the addition of SBRT for management of borderline resectable pancreatic cancer in the preoperative setting does not appear to be justified by 802501. And the role for radiation for specific subsets of high-risk patients with pancreatic cancer remains unknown. And Dr. Hong, in his excellent talk, which I strongly encourage you to watch if you're interested, the link is there, goes into the fact that all radiation is not created equal. The plans, the fractionation, the energy can be very different and very meaningfully different between radiation oncologists. Okay, as a medical oncologist, it was interesting to see the embrace of FOLFIRINOX after the presentation of the A021501 data, because remember, again, what RMA was really testing was the outcome of giving 8 rounds of FOLFIRINOX or modified FOLFIRINOX preoperatively. So our colleague, Dr. Alexandre Jacome in Belo Horizonte, Brazil, said he thought this meant that modified FOLFIRINOX should be the new reference standard regimen in borderline resectable PDAC. However, my counterpoint is we still have to reconcile the findings of S1505. You might recall from last year we discussed this. This was a study really comparing induction regimens, and we have FOLFIRINOX, a triplet, up against a doublet, gemcitabine, nab-paclitaxel, or gem-Abraxane. And what was so interesting was 2 did not necessarily appear to be less than 3 in terms of efficacy, whether we're looking at 2-year overall survival. So here now it's a slightly later time point than the 18 months we were looking at in A02501. And also the rate, and this is very surprising and counterintuitive to a lot of people, the rate of complete or major pathologic response was actually higher in the doublet than in the triplet. There was also slightly longer median disease-free survival after resection. So that leaves the medical oncologist who's pondering FOLFIRINOX versus gem-Abraxane looking rather like this. And I hope you'll forgive my use of a favorite internet meme of mine, but Larry David here is torn between 2 choices and can't quite make up his mind. And I feel like as a field, that's where we are. So the issue is becoming that of not just which regimen, but what sequence. And I think, and we'll talk about how this might be answered more definitively, I think the pendulum is swinging towards not just induction, but towards total neoadjuvant therapy. So our lessons from PREOPINK-1, also previously discussed in years past, were as follows. This was a really well done, I think, nationwide study from our Dutch colleagues. So it was multi-center in the Netherlands. Patients were randomized between these 2 arms. And so in one arm, there was upfront surgery and then adjuvant gemcitabine. And the other arm, there was this sort of gemcitabine, sensitized radiation, gemcitabine sandwich approach, if you will, then surgery, and then more gemcitabine on the back end as really true adjuvant therapy. Now you can see there that between the arms, no surprise, the vast majority of patients in the first arm, of course, went to the operating room. What I find interesting is the number there that were actually able to achieve an R0 resection de novo without any prior therapy was much lower than we would like or hope. So it was a 43% rate of R0 resection. What you see with the partially neoadjuvant approach is that fewer patients go to resection, but of those who do, there's a higher rate of R0 resection and a higher rate of N0 resection than again in the patients that go to the operating room with nothing up front. So PREOPINK-1 survival data have now matured, and we learned this again at the ASCO meeting in 2021. So there was the overall survival by intention to treat, and you can see there how the curves separate between the neoadjuvant chemorads cohort and the upfront surgery cohort. Among the patients that underwent resection, again, there seemed to be durable benefit to having undergone neoadjuvant therapy of some sort. Again, with a 5-year survival of almost exactly a third in that group. And this has been a remarkable couple of years. I can't tell you just how moved I was at ASCO several years back when I first saw the data supporting the use of adjuvant FOLFIRINOX in, again, a select patient population, but unprecedented overall survivals in traditionally a very lethal cancer. And this is not quite there, but it is reminiscent of the fact that we should not adopt an attitude of therapeutic nihilism when we approach our PDAC patients. I'll also point out, and this is, I think, the paradox of pancreatic ductal adenocarcinoma, it is still almost always a systemic disease, but one where surgery is the only cure. And I put that in inverted commas because to me, that is a very slippery word. To me, what cure means is being cancer-free durably, and again, conventionally 5 years. And I think that the systemic therapy, whether it's given upfront, both to reduce micrometastatic burden and better select surgical candidates, or afterwards to again prevent metastases from blossoming in the liver. So I have my props here. I always like to use these in clinic, especially when I'm demonstrating the very complex peripancreatic vascular patients. I use these with patients to show that we go through all of our efforts here really to protect this. To me, and some of you know this about me, I have had a Whipple myself, but for a neuroendocrine tumor. So I know just how fortunate I was not to need adjuvant therapy or really induction therapy of any kind. I went straight to the operating room, and I haven't really needed to do anything since other than surveillance. To me, the greatest tragedy, if I'm very honest with you, is someone upon whom we perform a Whipple, for a head or unsnit tumor, and even while they're still recovering from that surgery, because I can certainly speak to that operation's morbidity, which is substantial and life-altering. Even while they're still recovering, we see metastasis blossom in the liver, and then you realize that the whole operation was, in hindsight, moot and rendered, unfortunately, unnecessary by the systemic nature of this disease. So what I think is actually going to answer the question, I hope will, is PREOPANC 2. The sequel is sometimes better than the original. I hope that's the case here. Again, our Dutch colleagues have designed this very elegantly, where arm A is total neoadjuvant FOLFIRINOX. So 8 cycles of FOLFIRINOX up front. Obviously, they didn't wait for the outcome of A021501 before designing this, but I think this actually largely mirrors Matt Katz's chemo-only arm. And then the other arm, again, it's a mirror of PREOPANC 1 with an upfront chemo radiation sandwich with gem sensitization, surgery, and then gemcitabine again on the back end. Primary endpoint here will be overall survival, and you can see the secondary endpoints of PFS, R0 rate, and quality of life. Always important to build in prospectively. So I'm really fascinated to say that. I'm going to jump ahead and say that, and I'm going to get a soapbox here, family history is never non-contributory in an oncology clinic. And again, if you know me, it's because I have a germline defect myself. I have MEN1. That's what gave rise to my PNETs, which are numerous. In fact, they still reside in my remnant pancreas and always will. But more importantly for this discussion, in the last several years, I have seen germline testing come of age in every single pancreatic ductal adenocarcinoma patient. And what I really like about this NCCN workflow is, regardless of whether your patient gets directed towards the no metastatic disease setting or, heaven forbid, towards metastases, germline testing is recommended, in fact, strongly recommended, nearly mandated in both arms. And in the metastatic setting, as we know, it's important because it influences decisions around systemic therapy. In the clearly resectable or borderline resectable setting, it's important also for treatment decisions. And let's not forget the family members. I've described the tip of the iceberg phenomenon. If you successfully diagnose a patient, I say successfully, if you astutely diagnose a patient with BRCA, for instance, as underlying their PDAC, that's a discovery that has implications not just for them, for however long we hope they survive, but also for their family members. And you just see that sort of ramify out, sometimes across generations. And you know that provided that genetic counters are involved, that decision can then result in improved health, hopefully, for those other affected patients. But I think we've also learned that not all DNA damage repair defects are created equal. The reason I bring this up is it's not just about BRCA. Dr. O'Reilly and colleagues have been, I think, very forward-thinking in using gemcitabine cisplatin against BRCA. We also have to think about PALB2. And here, I wanted to focus on ATMs. This is a very important paper that came out this year in GI Oncology. So the figure shows the cumulative risk of developing PDAC by ATM pathogenic variant status over time. So you can see it really starts to take off in the 5th decade of life. And then below that's a table showing the risk of pancreatic cancer by ATM pathogenic variant and age versus non-carriers. And this is really interesting too. This comes up a lot actually now at tumor boards where we're informed by precision oncology or at least tumor genomic testing. And it turns out it actually really matters to consider zygosity. The responsiveness of ATM defective PDAC to platinum-based therapy actually does rely quite a bit on whether that is monoallelic or biallelic. And so that adds one more layer of nuance to our discussions. Again, in the area where we're aiming for precision, which I interpret to mean more or at least equal efficacy with less toxicity and less indiscriminate side effects. Okay, so I would be remiss not to point out the pancreas is a tale of two cell types, exocrine and endocrine. And it's funny because, if you poll the public, almost everybody knows that the pancreas is a hormonal organ. Everyone is largely aware of insulin. And so the endocrine function of the pancreas is actually, I think, much more broadly recognized than the exocrine function, but it's the exocrine function, the digestive function, that so bedevils us when it comes to cells of origin for adenocarcinoma. However, let us turn our attention here briefly at the end to endocrine and neuroendocrine tumors of the pancreas. So it's really important here to talk about surufatinib. This was a new agent. There's a beautiful discussion actually by our colleague Pam Koons of this drug after this data was presented at ASCO GI last year. So what happened here was a phase 1 dose escalation and dose expansion trial was conducted to evaluate and confirm the efficacy and safety of surufatinib in US patients after it had been successfully demonstrated in China. So dose escalation was completed, the maximum tolerated dose was determined, and the MTD that was recommended for use in phase 2 was 300 milligrams. So then dose expansion completed enrollment of both pancreatic and extrapancreatic NETs, as you can see there. Now, the key efficacy endpoints for the dose expansion cohorts were investigator assessed PFS at 11 months and overall response rate. And secondary objectives included safety and PKs. And essentially what we see now is that surufatinib has demonstrated anti-tumor activity in heavily pretreated US patients with progressive NETs and has shown also a manageable safety profile. And the FDA has to weigh in on whether or not they're going to approve this drug now, I believe by the end of April, certainly before the summer. So again, I think 2022 will be a year where we see the needle move, not just in adenocarcinoma, but in NETs. So in closing, I just want to say thank you. Being a part of this community has sustained me during the time of COVID. I miss you all terribly. I wish I could see you in person, but safety first. I'm very grateful to Gil for hosting us in this virtual forum, and I wish you a very productive colloquium. My contact information is there. I wish you the best of health.
Hi, my name is Niu Sanford, and I am a GI radiation oncologist at UT Southwestern in Dallas, Texas. And I am very excited to be talking about updates in GI radiation therapy for the 2021 OncoAlert Colloquium. So as you know, there are many subsites within the gastrointestinal tract. So my talk is broken up into the following 4 sections. So starting with esophagus and gastric cancers. And again, this talk is by no means exhaustive of all the advances that have happened over the past year, but I wanted to highlight some of the studies that were presented with a focus on randomized trials that were presented at meetings over the last year. So the first study I want to talk about, which was presented at ASCO in 2021, was the NEO-AEGIS study. This stands for Neoadjuvant Trial in Adenocarcinoma of the Esophagus and Esophago-Gastric Junction International Study. This is a study comparing the cross regimen, which is preoperative chemoradiation followed by surgery, versus perioperative chemotherapy, either the MAGIC or FLOT regimens in esophagastric and G-junction cancers. So here was the original study design. So patients with esophageal or gastroesophageal junction adenocarcinoma, stage 1 to 3, were randomized to perioperative chemotherapy with ECF or neoadjuvant chemoradiation for the cross regimen. Here, radiation was given to 41.4 gray, such as was done in the cross regimen. The primary endpoint was overall survival, and secondary endpoints included disease-free survival, time to treatment failure, tumor regression grading, R0 section, toxicity, postoperative complications, and health-related quality of life. Initially, the study was designed as a superiority trial with the goal of showing superiority of the cross regimen. However, in 2018, there were a couple amendments that were made. First was in the treatment for the perioperative chemotherapy. With the publication of the FLOT4 study, FLOT became an acceptable chemotherapy regimen for the perioperative arm in addition to ECF. Also, this was changed to a non-inferiority study as per powered by the first futility analysis in December of 2018. So again, key elements of the trial design, this is all adenocarcinomas. Stage 1 to 3, the tumor had to be less than 8 centimeters, clinical T2 to 3, any nodal staging per the AJCC 7th staging manual. All patients were initially staged with a PET or EUS unless obstructed. Radiotherapy quality assurance was performed, and then complications were very strictly defined. Here's just a slide based on the recruitment. You can see this was a European study and recruit in Ireland, UK, Denmark, and France. And who are the patients? So there were 184 patients in the perioperative chemotherapy arm and 178 patients in the cross arm. The median age was 64 years. The majority were male. For the chemotherapy arm, the majority got ECF per the MAGIC regimen, and 27, a smaller proportion, got FLOT. The majority of patients were T3 staging, and the majority had positive nodes based on imaging. So in terms of postoperative complications, I didn't present here, but the chemotherapy arm had higher rates of neutropenia, while the radiation therapy arm had a statistically insignificant but numerically higher rate of postoperative ARDS. With preoperative chemoradiation, pathologic response, TRG, and R0 resection rates were all improved with preoperative chemoradiation. However, there was no difference in overall survival. The hazard ratio was 1.02 with a 95% confidence interval that clearly crossed 1. So the conclusions from this presentation were that perioperative chemo was not unacceptably inferior to cross regimen with 3-year survival of 57 and 56%. Markers of response were significantly better in the cross arm. There was no significant difference in complications or specific index complication rates, post-op mortality. So there's also no negative effect of preoperative radiation therapy. So clearly, the results thus far show similar outcomes and toxicities of the two treatment arms. So we await further follow-up in the full publication. I wanted to also quickly present a study presented at ASTRO of 2021. This study looks at the question of dose escalation in esophageal cancer. It's called the Concorde or PRODIGE 26 study. This was a multi-center study in France conducted over 2011 to 2019. Unlike the prior study, these were all unresectable or medically inoperable patients. They received either 50 or 66 gray of radiation to the primary tumor in the nodes, and both with 40 gray of elective nodal coverage. They also received concurrent and adjuvant FOLFOX. The primary endpoint was 2-year local regional progression-free survival. Of a total of 217 patients, the majority, 88%, were squamous cell cancers, 74% were stage 3, and there was no difference in median overall survival or the primary endpoint progression-free survival shown in the slide, and also no difference in toxicity. So the conclusion of the study, again, was there's no difference in toxicity or efficacy between 66 versus 50 gray of definitive chemoradiation in unresectable, mostly squamous cell esophageal cancers. To put this into context, this was a third negative major trial for dose escalation in esophagus. The other ones were the Art Deco trial presented a year prior and the older intergroup 0123 trial. Moving on to rectal cancers, just taking a look at my timer. We're on time. Rectal cancer. So this study was presented at ASCO 2021. It was an update of the OPRA study. And the title of the presentation was Survival and Organ Preservation According to Clinical Response After Total Neoadjuvant Therapy in Locally Advanced Rectal Cancer Patients, a secondary analysis from the OPRA trial. So just a reminder to the audience of the OPRA study. This was a study of locally advanced rectal cancer, stage 2 to stage 3. The randomization of the study was on sequencing of neoadjuvant therapy. So patients either received consolidation chemotherapy or induction chemotherapy. So chemotherapy or radiation first. After 8 plus or minus 4 weeks, they were assessed via a combination of MRI, endoscopy, and exam. And they were put into 3 tiers: a clinical complete response, an incomplete clinical response at the bottom where there is gross residual tumor, and then something in the middle called a near complete clinical response. Patients who had a complete response, a clinical complete response, were recommended to go watch and wait, so avoid surgery. Those with an incomplete clinical response were recommended to have surgery with total mesorectal excision. And then those with a near complete clinical response could go in either direction. So who were the patients? In each of the response categories, there were 124 and 114 patients for complete and near complete response, and fewer 55 patients in the incomplete response. Other important things from this slide was that the median tumor distance from the anal verge was about 4 centimeters for all patients. So these were more distal tumors. The majority of patients were T3, and the majority were also node positive. Importantly, for patients who had a clinical complete response, 98% chose watch and wait versus only 15% with an incomplete response. And those with a near complete response, the majority, 82%, chose watch and wait. So this slide shows outcomes in organ preservation and survival by complete response. And you can see for all of these outcomes, organ preservation, disease-free survival, local recurrence-free survival, and metastasis-free survival, the best outcomes were in patients with a complete response. The worst were incomplete response, and then near complete response was in the middle for all 3 outcomes. And this was all statistically significant. So the conclusion from this, secondary analysis was that the 3-tier clinical response assessment schema based on endoscopic and rectal examinations has prognostic implications. With the expanded watch and wait eligibility in the 3-tier schema, almost half of the near complete response achieved organ preservation by 3 years. While treatment impact cannot be excluded, the survival difference between response groups points to biological distinctions between the 3 tiers. I also wanted to quickly touch upon the study looking at watch and wait in rectal cancer with short course radiation. So as a reminder, the standard chemoradiation for rectal cancer is about 50 gray over 5 weeks with either capecitabine or 5-FU. This was a regimen that was used in the OPRA study. There have been several studies, large randomized trials comparing short course versus long course chemoradiation in the preoperative setting, showing no difference in outcomes. The Rapido study also showed the feasibility of short course TNT in rectal cancer. So not surprisingly, there has been increasing interest using watch and wait with short course radiation, which is generally 5 gray times 5 treatments for a total of 25 gray. So this was an institutional prospective study conducted at WashU. This included patients with stage 1 to 3 rectal cancer. They all started with short course radiation, followed by consolidation chemotherapy. Of those patients, about half, 43, had a clinical complete response and thus had non-operative management, while the rest underwent surgery. And the outcomes they looked at in this series were local regrowth-free survival, regional control, distant mets, disease-free survival, and overall survival. In terms of the results, not surprisingly, patients with a clinical complete response had lower tumor and nodal staging as compared to those who did not have a clinical complete response. With a median follow-up of 30 months, the persistent clinical complete response rate was 80% of those with an initial complete response. And the 2-year local regrowth-free survival was 81% in the initial clinical complete response group. And importantly, all patients who actually had local regrowth were successfully salvaged. You can see the other outcomes here and also read the full publication in the Red Journal from October of this year. But the main conclusion of this study was that short course radiation followed by consolidation chemotherapy may be a feasible organ preservation strategy in rectal cancer. Additional prospective studies are necessary to evaluate the safety and efficacy of this approach. And just so you know, there are 2 ongoing European trials, randomized trials, assessing watch and wait with short course radiation. The first one compares short course radiation in total neoadjuvant therapy versus long course chemoradiation total neoadjuvant therapy. And patients, depending on their response, go either to surgery or watch and wait. The second study actually compares surgery versus long course chemoradiation and watch and wait versus short course radiation, watch and wait. Okay, moving on to pancreas cancer. So a couple important studies that I will quickly review because I see that we are, of course, going over time. So the first one is the Alliance study looking at preoperative modified FOLFIRINOX or modified FOLFIRINOX plus hypofractionated radiation therapy for borderline resectable pancreas cancer. So the study schema is shown here. Patients in arm A did not get radiation. They got 8 cycles of FOLFIRINOX. Followed by surgery, and then 4 cycles of adjuvant FOLFIRINOX. In contrast, arm B got 7 cycles of initial FOLFIRINOX and radiation, which could be either SBRT, 33 to 40 gray and 5 fractions, or hypofractionated radiation therapy, which was lower dose, 25 gray and 5 fractions. This was followed by surgery and adjuvant chemotherapy. This slide is important because it's important to contextualize the findings in regards to how the trial was designed. The primary endpoint was an 18-month overall survival rate. Secondary endpoints are shown here. Importantly, there was a futility analysis in either arm in which less than 37% of the first 30 patients, if fewer underwent R0 resection, then that arm was closed. The sample size was 62 patients in arm to detect an improvement in 18-month overall survival rate of 13% over historical rate of 50%. So this was not meant to be a comparison between the 2 treatment arms, but rather compared to historical outcomes. So here's a consort diagram. There are 54 patients randomized in arm A, the periop chemo arm, and 56 patients randomized to arm B, which was the preoperative chemoradiation arm. And here are the outcomes. So arm A, the arm with perioperative chemotherapy, was declared efficacious with an 18-month overall survival rate of 66.4%. In comparison, arm B with preoperative chemoradiation did not meet requirements to conclude efficacy with an 18-month overall survival rate of 47%. Importantly, the resection rate was quite a bit lower in the SBRT arm. There were no pathologic complete responses in the periop chemotherapy arm, but 11% in the preoperative chemoradiation arm. There are some caveats of the study that are listed here, including an imbalance in arms. The median CA19-9 was higher in the radiation arm, suggesting that these patients might have had more advanced disease. Radiation was performed at a variety of sites with differing expertise in pancreatic cancer radiation. And also a question of whether the volumes of radiation might have been too small. Quickly, I want to talk about the PREOPANC study, which had long-term results presented at the ASCO meeting. So this was a study of 16, including 16 centers in the Netherlands, a rather large study of 246 patients that were randomized to either upfront surgery and adjuvant gemcitabine or gemcitabine with radiation surgery and adjuvant gemcitabine. So upfront surgery versus preoperative chemoradiation surgery and adjuvant gemcitabine. The radiation dose used in the study was 36 gray and 15 fractions. So what were the findings? So the median age was about 66 years with a pretty even split between resectable and borderline resectable cancer. In terms of surgical outcomes, you can see that patients who had neoadjuvant chemoradiotherapy had higher rates of R0 and N0 resection as opposed to those who went upfront surgery. And this was shown at the initial findings of the PREOPANC study. However, the updated findings of the PREOPANC study were significant in that the 5-year survival was over tripled in patients receiving neoadjuvant chemoradiation as compared to upfront surgery, 20.5% versus 6.5%, without a difference in median overall survival. So if you look at this graph, you can really see that initially the curves are overlapping, but as you go later, up to 60 months, they start to split, showing an improvement in outcomes for those receiving neoadjuvant chemoradiation. When stratified to patients that underwent resection, that improvement in outcomes with neoadjuvant chemoradiation persisted. It also persisted when looking at patients that started adjuvant therapy. So patients who received chemotherapy at all, including the upfront surgery arm, the addition of radiation and chemotherapy preoperatively, again, tripled 5-year survival. Here's 31.2 versus 10.3%. So I think this is a very intriguing study showing improvement in long-term survival, potentially with the addition of preoperative radiation. We await the long-term, the publication of the long-term outcomes of the PREOPANC study to better understand these findings. Just want to point to this great read in JCO this September, which is a very nuanced editorial looking at the value of neoadjuvant radiation therapy in the management of pancreatic adenocarcinoma. All right, in the last minute, I wanted to briefly talk about anal cancer. So as you all know, the current standard of care for anal cancer, locally advanced, for stage 1 to 3, I should say, so basically non-metastatic anal cancer, is chemoradiation with 5-FU and mitomycin C. Per the RTOG 0529 study. The dosing in the study varies based on the T and N staging. For a T2N0, the dosing is put here. For a T3 and above or node positive, the dosing is here. So for this section on anal cancer, I just wanted to touch upon 2 ongoing randomized studies looking at treatment for anal cancer. Both the studies, the premise for both of them is that the current treatment schema is either under treatment for the more advanced tumors or potentially over treatment for the early stage tumors. So this is a study called the DECREASE trial aimed toward earlier stage tumors. And quickly, as sort of that I just described, the concern is that current treatment paradigms for early stage cancers may be over treatment, meaning that they have high toxicity without a clear benefit in cancer outcomes. So the question is, can we de-escalate treatment for early stage anal cancer? So the design of the study is a randomized study, a 1-to-2 study, a 1-to-2 randomization, where patients either get the standard 0529 regimen or they get a de-escalated treatment regimen where both radiation and chemotherapy are de-intensified. The radiation dose goes to either 36 or 41.4 gray for T1 versus T2 tumor, and the elective nodal volume is also decreased. And then patients get just 1 cycle of mitomycin C instead of 2 cycles. The primary endpoint is 2-year disease control and also improved anorectal health-related quality of life. So this study is currently accruing with a target accrual of 252 patients. Second study I just wanted to briefly touch upon. So this is a study for more advanced anal cancers. So this is a randomized study of nivolumab after chemoradiation for high-risk anal cancer. So these patients get standard concurrent chemoradiation and then are randomized to either observation or adjuvant nivolumab. And the primary objective is to evaluate whether therapy with nivolumab after combined modality therapy improves disease-free survival. Current enrollment is estimated about 200, so it's enrolling at a very brisk pace with, I believe, a target between 300 to 400 patients. And I believe that is it. So thank you for your attention. Feel free to reach out to me if you have any questions, and have a great Happy New Year. Thank you.
Good day, everyone. My name is Johan de Munter. I am a cancer nurse and I work as a cancer nurse manager in the University Hospital in Ghent in Belgium, and I'm currently EONS president. And first of all, I would like to thank the organization for inviting EONS to the OncoAlert Colloquium 2021 and give us the opportunity to bring this on this platform among all these great presentations with our colleagues in cancer care. So today we're going to talk about in cancer nursing the effect of COVID-19 on the nursing workforce and the ways how we can build a better back to tackle the burden of the pandemic and moving forward to increase the best of cancer nursing in cancer care for the future. So first of all, I have no disclosure for this. If you look into the agenda where I want to talk through with you is cancer care and cancer nursing, the cancer care and the global pandemic, the role of cancer nursing and the challenges in cancer nursing and cancer care currently, and also for the future, and also moving forward in cancer care to deliver the best of cancer nursing in the future from now on and beyond the pandemic into the future to deliver the best cancer care for our patients. So if we're talking about cancer care and cancer nursing, then most of the general public perceive the work of cancer nursing during treatment in the hospital for cancer patients. But if we look deeper into it, we see that cancer nursing are providing on different levels of cancer care support and work. And so we see they are also active in health promotion and education, also in prevention and screening. We see in diagnosing and staging, then of course treatment and the supportive services during the treatment and beyond the treatment for patients and their families, for example. And then we see also like now also in the short and long term follow-up services, as we see people living beyond their cancer. Luckily, we see that also the survival rates are increasingly going forward, and that's good for our patients. So we also need to set up the survivorship services to tackle, of course, the physical effects of the cancer treatment and the cancer before, but also for psychosocial support for our patients after the treatment and tackle and beyond their treatment and their disease, so they can back going to their daily life and integrate in their social environment. But also, unfortunately, we see that not all cancers can be treated or can be cured. So we also have to invest in good end-of-life services, and cancer nurses have a long history also providing end-of-life and palliative care for patients near on the end of their treatment and beyond it, also for the patients and their families. So cancer nursing is involved in a lot of areas in cancer care, and mostly it's seen in treatment, for example, in surgery, in internal medicine, in for example, providing this medication and the treatment for patients. But in the whole spectrum of cancer care, nurses are increasingly important to support the services and deliver the best of cancer care across Europe. And in the beginning of 2020, the whole world globally, we were tackled by this pandemic that has a massive impact on how we delivered healthcare. And everywhere, patients were advised to stay at home, not coming out, because we want to decrease the infection levels with our patients. But unfortunately, we saw also that it has a massive impact on the diagnosis of cancer. And therefore, I think it was important that we also deliver the right message to the patients and to the people. So if patients or people at home had like symptoms or signs that could be related to an unknown illness, it was still important to go to the hospitals. And what we see is during this pandemic and after going to the end of the pandemic is that we see that, for example, now we see like a late diagnosis in cancer care. And it is something we have to tackle and think about in the future, how we want to deliver this message. So screening, prevention and screening is massively important, and deliver the right message to people at home if some signs or symptoms are occur that could be related to cancer, it's still important to go to the healthcare provider, for example, the general practitioner, or going to the hospital to cancer care services to get that investigation and to see if it's cancer or not, and hopefully not. But if it is cancer, it's massively important. We start as early as possible at the treatment, and then we deliver that treatment on dose on time. But also during the pandemic, it was massively important for healthcare providers to stay safe in that pandemic so we can deliver good cancer care. But also that was under pressure during the pandemic because also cancer nurses and other healthcare professionals were demanded to work in the COVID wards to give good care to patients with the COVID-19 infection. But if we see what the role of cancer nurses, they have a massive expertise in infection control. So that expertise was very valuable during the pandemic because we know to how handle patients that has neutropenia, that have their immune compromised. So we have a lot of history on working on infection control. So what we already did is before is analyzing this infection data. So we know what we're dealing with if it's coming to infection control. We are used to treat and protect patients from infectious risks. For example, we putting patients in isolation, giving good guidelines. Also the hygienic measures. We were used to work, for example, with a mask, with gloves, with hand hygiene. We know this is very important. And we also know how to do the prevention on this infection risk and giving patients and other people advice how they can tackle and also prevent to get an infection. And if you look into the nursing research, we see have a massive research in cancer nursing about research, about guidelines about infection risks and prevention. So this is something that was coming very handy during this pandemic and sharing this expertise with other nurses and other healthcare professionals, how they can tackle and doing on prevention and decrease the infection risks by informing and educating, for example, our patients, their family members, but also other healthcare professionals. And that was quite important during this pandemic. Unfortunately, we see there are massive challenges already in cancer nursing. We see already in cancer nursing across Europe and also globally that there is a general nursing shortage. And we see there are recruitment barriers because we see a high level, it's like a hardworking, it's also they have occupational barriers that prevent people going into healthcare because also we have to think about occupational safety in our work environment, especially if you think about cancer nursing and how we're handling these hazardous drugs. It's important that we handle them safely for our patients, but also for the healthcare professionals around the patient. We also that it's very difficult for cancer nursing to move around Europe to work in other countries because there is a massive differences between how cancer nurses are educated and provided and supported and recognized. We also see the lack of nursing recognition. In some countries we see, and this is coming later in this conversation about the RECAM project, that we saw that in some countries there is the recognition is high, but in other countries cancer nursing recognition is still low. And this is also a massive challenge if we want to increase cancer nursing and deliver good cancer care in the future in Europe and globally. But also we're seeing it was before by the hard work, by the hard psychological burden of cancer care. We see there was also an increased risk of burnout and dropout, but now even with the pandemic and the massive work on that one and everything that happened across globally for cancer nursing and other healthcare professionals, we see there's a more increased risk of burnout and dropout and people stepping out of healthcare and doing other professions. So that is something we have to think about, and these are real challenges for cancer nursing in the future. And we see this could have like an ongoing negative impact. And if we look into this as the general nursing shortage and recruitment barriers, we see there are also increased patient safety barriers that coming up. And then we have this increased risk of burnout and dropout. And this is making a vicious circle. And then by all these factors there is also an increasing general nursing shortage and recruitment barriers. And this makes that we are in a negative circle that's going down. And this is something we have to break through in the future if we want to deliver the best cancer care in the future. And how we can do this is also looking at the challenges in cancer care, not only in cancer nursing, but if you look into cancer care, we see there is an increased demand of care, not only by, for example, now with the pandemic, but also in cancer care, we have like an increased demand of care with new therapies, new possibilities. People are longer in treatment. So there's an increasingly demand of care for our cancer patients. And that is something we have to tackle in the future. We see that there are product and equipment shortages. For example, during this pandemic, all these preventive materials that we needed, the protective materials we needed, there were shortages in different parts of the world. So that is something we need to think about in the future. If you want to deliver good care, we need also to protect our healthcare workers and also especially the cancer nurses to protect them so they can deliver and go on by providing quality and quality cancer care. But also we've seen there is a massive change in care environment where we're seeing that we now have to reinvent also ourselves how to, during this pandemic, and how we want to deliver this cancer care with these new measures. We need to think about, for example, increasingly using e-health, telemedicine, e-health platforms. And that is something we have to teach and learn to work with and reinvent cancer nursing and how to deliver the right and the best care for our patients using these new technologies for now and in the future. And we have to think about what's the right balance to use it. For example, when patients have to come to the hospital or where we can do an e-health or teleconsult for them at home or with, for example, their family members. We saw also that there was a disruption in cancer care systems where cancer care was totally going down so that people can work, for example, for COVID patients. So there was a disruption in this cancer care. Also, we see there was lower numbers in, for example, in diagnosis. And that is something we have to think about in the future, how we can tackle this. And during this pandemic, how we can move forward with delivering the best cancer care, unless and even when the pandemic is still going on. This is very important so that we don't see late diagnosis for our patients. And so we can move on treatment, because also in treatment, we want to give dose on time. But also, if we want to move forward and during this pandemic, we see an increased need of psychosocial care. For example, cancer nurses have to think to their patients. They don't have any visitors, the patients. So also for cancer nurses, we see in patients increased psychosocial and psychological needs in our patients, but also for the cancer care workforce and especially also for cancer nursing, to increase psychosocial support is needed during this pandemic, and that we don't have any more dropouts for cancer nurses, but also the burnout with cancer nurses will increase and people will step out of the job and going search something new. And that is what we don't want, because then we lose a lot of expertise to other areas in the healthcare. If we look at the RECAN project, and that was something that EONS did together with is Recognition European Cancer Nursing. And what we saw there is while cancer nurses are really devoted and love their jobs, they have important relationships with patients and their families, and that is something that was very handy also during this pandemic, so they can trust us. And if we look at this, and cancer nurses are the most trusted healthcare professionals in the world, but we are still overloaded with work. And there is massive differences between task and responsibilities across Europe. If we see how cancer nurses are educated or very massively differently in a lot of countries across Europe and also globally, there is also a lack of recognition. We see that there are differences in professional status and autonomy, career possibilities. In some countries there are, in some countries there are not career possibilities. There are a lot of safety issues. Think about delivering hazardous drugs and how we can handle this is very important. And also about the management hierarchies, teamwork and support. In some countries there is, in some countries unfortunately there isn't. So that is also something very important. Even in this pandemic, this is also coming to the forefront during this pandemic. And then also we see that EONS have this strategy, this care strategy, and that is something we want to use also in the future. And now also is the communication advocacy for cancer nursing, the research and educating. And therefore, I think in the future, we need more collaboration and this innovating that EONS will bring for cancer nurses. We will want also think about like how we can remove practice barriers in the future. We think about the burnout concerns, and we need to see also increased interest in nursing, and that is also by the recognition, increasing that recognition. And how you can do this is also starting with education. And therefore, EONS is always proud that they have worked on this cancer nursing educational framework that's available on our website, where we have like these updates for years now, so we can deliver the best cancer nursing education. And this is a framework that can adopt it, and hopefully across Europe, this will be adopted. And in the end, this will deliver the right education to all cancer nurses, and this will increase movability across Europe, so we can all give the best education to cancer nurses, so they can give the best care to our patients. But also we have to invest in e-health in cancer care. We have to think about, for example, telehealth introduced and expanded. And also the pandemic also promoted the widespread use of telehealth. And this jumpstart also everything that we can use to do this. And in collaborating with other healthcare professionals, how we can implement this and use this to, for example, to reach our patients, to get in contact with them, to get better information, to share information among healthcare professionals, but also to share information with other healthcare professionals in different countries across Europe, but also globally, and discuss, for example, cancer care cases, so we can deliver the best cancer care and we learn from each other, because also that's a very important issue. And if you want to see how we want to move forward, I think education and training will be key. But also research and development is something we want to move to put forward, and that's something that EONS with the research working group is massively investing in, but also taking leadership and management. And if we think about how we're going to handle this, is also coordination will be key. Not only coordination in care, but also thinking about the virtual coordination, how we want to move forward in the future and use these virtual technologies to deliver the best cancer care. But also we need to think about our patients, because they have a lot of knowledge, how they are really the experts in what's going on. So more and more, and we want to involve them in this education, but also in research and in the management, and thinking how we want to coordinate the cancer care across Europe, and also cancer care locally, for example. But we need to invite patients, and they have this in public involvement for deliver the best cancer care that is tailor-made to the patients themselves. And this is important, that we start with prevention and risk reduction, think about screening during diagnosis, treatment, and going on during survivorship and end-of-life care. But not only for cancer care, it's important for looking to the patient. It's also important that we think about together with other healthcare professionals. And therefore, it's important we build strong collaborations. For examples, and at EONS, what we did is like establish how a guide to establish a cancer nursing society nationally, for example, because if you bring people together, you bring knowledge together, and that's so much important. But also think about other healthcare professionals and a healthcare workforce. And that is why it's so great to be here on this platform, OncoAlert platform, because other healthcare professionals in cancer care, we're working together, we share knowledge to each other, we make inspiration to each other, we exchange this to each other and see how we can use it and talk to each other. And that is really how we can work as a team and doing teamwork on cancer care. But also it's important that we, and that's brings us also these successes, is like this multidisciplinary collaboration on the world, but also on the national and international level. This is much important, and we should share the successes, but also celebrate them, so we can assist each other, and in this way we can support, and we support cancer care globally. Also, it stays important that what we did before is virtually is sharing this information. And these are examples how we can share information is by delivering these webinars on systematic basis. For example, these were safety webinars on occupational safety, but also, for example, the young cancer nursing, the upcoming workforce that will be very important for the future because they are the future of cancer nursing. It's important we strengthen them and give them the right tools to empower them and to deliver the best cancer care and to deliver the best cancer nursing out of themselves. And this is also we do in collaboration with our other healthcare professionals. So this is something, an example is the Nightingale Challenge, where we talked about important topics, for example, in lifestyle and cancer, but also like burnout, building resilience, standing up against bullying, emergencies in oncology settings. So it's all about sharing this information, and this is how we can tackle this, the best cancer care in the future. But it all starts with prevention, and that's why EONS now is building on a cancer prevention plan, and you're all invited to be part of it. So that's important. But because also see in the European Cancer Beating Plan, we see that the massive importantly to invest in prevention so we get lower numbers of cancer in the future, because prevention is the key, and this is something we have to do all together, I think. And if we work on cancer care for the future, I think the best way to predict the future in healthcare and to deliver the best cancer care is to create it together. So thank you very much. And if there are any questions, we are happy to answer them. Thank you.
Hello everyone, my name is Merel Van Klinken. I'm a cancer nurse and a palliative care nurse in a Dutch cancer center in Amsterdam. Also, I am an EONS executive board member. I would like to thank the organization for this EONS session and for the opportunity to talk to you about the Cancer Nursing Index. So, what are we going to talk about? As the European Oncology Nursing Society, we have developed the Cancer Nursing Index, but why would we need this? I will go into that in a minute. Of course, I will go into the process of the development, but the results are the most important part. After this, I will go into the national profiles and the conclusions derived from the Cancer Nursing Index. First of all, the Cancer Nursing Index was developed by the Advocacy Working Group consisting of these members. In the project on recognition in cancer nursing, EONS initiated, important differences in cancer nursing across Europe were highlighted. EONS Cancer Nursing Index 2020 was developed by the EONS Advocacy Working Group to illustrate the development and status of the nursing profession in Europe. The purpose of the index is primarily not to rank some countries as better than others, but to illustrate cancer nursing profiles, differences, and areas in need of development. The index could be used in the development of cancer nursing in each country, but also for general European progress. The Cancer Nursing Index features a series of maps that present an overview of cancer nursing situation across Europe. This data, including the maps, are used for advocating for cancer nursing. The index was developed based on a survey on patient and occupational safety, which was translated in 9 languages and was sent out to nurses in Europe. We have collected over 650 responses from 40 countries. After data was collected, there were interviews arranged with leading cancer nurse experts to confirm and check the data. All this was complemented by workforce statistics, and this has led to the European Cancer Nursing Index. The Cancer Nursing Index shows the status of cancer nursing in different countries in Europe in terms of education and career development, patient and occupational safety, recognition, working conditions and impact, and workforce statistics. The index includes 22 items with scores from 0 to 100. We found that there were a large variation between countries in overall scores, with Ireland as highest scoring country with a score of 78 out of 100. As you can see in the picture, the darker green countries scored highest and the light green countries scored lowest in overall scores. There were also differences between the different dimensions. I will go into these different dimensions right now. So the first dimension is education and career development. This dimension consisted of 5 items with a maximum total score of 23 and focused on cancer nursing education, academic development, level of established advanced practice roles, and the recognition of the EONS education framework. Countries who scored highest in education and career development were Norway, the UK, Ireland, and I'm proud to say the Netherlands. 44% of the countries do not provide university-level nursing education that is recognized on a national level, but on the other hand, 33% of countries do offer master programs in nursing, and 26% of countries have professors in cancer nursing. A second and very important dimension is patient and occupational safety. This consisted of 8 items with a maximum score of 36. The items consisted of access to safety guidelines and PPE, or handling cytotoxic drugs, testing of occupational exposure, guidelines for nurses who are pregnant, wanting to become pregnant, or who are breastfeeding. Also, whistleblower policies were looked into. And of course, the formal training nurses receive before administering cytotoxic drugs and how often nurses prepare these drugs. In this dimension, Germany and Belgium scored highest. The third dimension of the Cancer Nursing Index was working conditions and impacts. This consisted of 4 items with a total of 20 points. This covers the level of adherence to the European Working Time Directive, the risks of negative consequences nurses face when denying handling cytotoxic drug, when they are pregnant, for example, and the consequences of nursing shortages such as closed beds or delay in treatment. In this dimension, the mean score was 15, and Bosnia and Switzerland were the 2 highest scoring countries with 19 points out of 20. The Cancer Nursing Index also looked into the recognition of cancer nursing as a profession. Here you can think about topics like the level of establishment of nurse-led care, whether the national cancer plan of the different countries included nursing issues, the proportion of cancer centers with a dedicated board position for a cancer nurse, and whether a national cancer nursing society was established. This dimension had a mean score of 8, and Cyprus, Denmark, and Sweden were the highest scoring countries with scores of 15. So the last dimension was on workforce, and it measured the number of practicing nurses per 1,000 citizens. So on this slide, you can see the scoring. If there are less than 6 nurses practicing per 1,000 citizens, the country would get a score of a 0. If there are over 8 nurses per 1,000 citizens, the score would be 3. In the picture, you can see the darker the country, the more nurses per 1,000 citizens are practicing. Each country's National European Cancer Nursing Index profile can be downloaded from this website. Here you can describe and compare results and look into strengths and weaknesses of your own country. You can also find recommendations and improvements. And as said, this work was confirmed by leading national cancer nursing experts before dissemination. Also, the maps will be updated every 2 years to show the progress that is being made. Our conclusion is that cancer nursing needs to be strengthened in all participating countries to guarantee high quality and safe cancer care. We found a large variation in scores between the 5 dimensions, illustrating the differences in cancer nursing profile between the countries. While some countries scored higher in education and career development and or safety, others scored higher on working conditions and impact. Concerns that were found mostly revolved around education and the lack thereof. As already mentioned, we identified some topics that are in need of attention regarding patient and occupational safety, thanks to the index. This has led to a series of webinars on this topic, which you can access on our website. It is the vision of EONS that cancer nursing will be recognized by the cancer community and by national and European level policymakers as a profession with specialized training and qualifications that need to be upheld. Next to that, working conditions should be optimal, providing a commensurate financial income and promoting well-being. This can only lead to an improvement in the health and clinical outcomes for patients with cancer everywhere. Finally, we envision that all cancer nurses will become confident and empowered nurse leaders in research, practice, and education. So, lastly, I would like to challenge you all. Like I have said, we are planning a revision of the Cancer Nursing Index. The first one was 2020. So like you can guess, in 2022, we will provide an update. In 2020, we had 650 responses. So I would like to challenge you all to help us double this number. The survey will be translated into even more languages. And the focus will be more on the individual nurse's workplace instead of the situation in their country. The survey will be shared through EON's social media platforms, through the member societies, and during national conferences. So I hope you are up for this challenge. I would like to end this presentation with some quotes from different nurses across Europe we've collected. So first, there is an Irish cancer nurse. When nurses are working a long time in the same unit, they will forget risk exposure and don't really concern themselves with it. Also, there are no guidelines for safe handling of cytotoxic drug for pregnant and breastfeeding staff in my hospital. Second quote is a European cancer nurse. We have to learn on the job. After a few shifts side by side with a colleague, we administer chemo and other cancer drugs, but I have no formal training for this. This is an Austrian cancer nurse. She said, I would like to be offered continued online training in how to handle hazardous drugs. And lastly, a Spanish cancer nurse. She said, there is a need for better training and more awareness of the health risks. So these quotes provide learning experience. I would like to thank you so much for your attention. Please look forward to the Cancer Nursing Index in 2022. I would like to thank OncoAlert for this opportunity to talk. And please, if there are any questions around this topic or EONS related, send me a message via the below platforms. Thank you.
Thank you all for joining us this day 4 and a warm invitation to join us tomorrow for day 5 of the colloquium for our special sessions, from immunotherapies, targeted therapies, to financial toxicities, inequities, and the SWOG sessions with an amazing faculty. Make sure to join in. Reminding you that this colloquium video is now available on our YouTube channel and will be available on demand from now on. These will also be available next week to our partners at the European School of Oncology and eCancer on their websites. From all of us at OncoAlert, thank you once again for joining us and look forward to seeing you tomorrow.